Alright, so today we're going to be talking about methods used to reduce hospital readmission rate for patients suffering from chronic heart failure. So in the abstract, we outline the project. This project addresses methods to reduce hospital readmission for heart failure patients. It asks two questions. What are the consequences of frequent readmission? We're going to look at both the adverse patient outcome as well as financial repercussions. And then what intervention can we utilize to prevent readmissions in the future? The people involved in this type of project are going to be the nurses, primarily nurses at the bedside who are caring for these patients in the hospital, the physicians, both in the inpatient and outpatient setting, and then of course the patients themselves. So just a little bit of information about heart failure. Hospital readmission for heart failure patients are costly and contribute to poorer patient outcomes. Heart failure is a disease that affected approximately 5.7 million Americans in the year 2009. Heart failure patients have a 13% readmission rate within 15 days, a 25% readmission rate within 30 days, and a 50% readmission rate within 6 months. So that means within 6 months of their initial hospitalization, over half of these patients are coming back into the hospital for the same or similar symptoms. 80% of patients with heart failure are over the age of 65. Just a little more statistics here. Heart failure accounted for 1.1 million hospitalizations in the year 2006. These admissions constitute approximately $27.9 billion in healthcare costs. 75% of those costs are directly attributable to hospital readmissions. So as I kind of touched on a minute ago, heart failure is a disease that disproportionately affects the elderly, those of low socioeconomic status, and those in minority groups. So unfortunately, this disease targets those who may already have decreased resources for their own care. And also increased readmission can lead to increased morbidity and mortality, decreased quality of life, and a decreased availability of resources for other patients who are here in the hospital. The objectives of this project will be to suggest interventions that can be utilized to reduce readmission rates, outline education that is necessary for the patient, needs to be given both during hospitalization, at discharge, and after discharge. Outline community resources that may be utilized to help prevent readmissions. Describe methods of tracking data related to readmission, and to describe methods to evaluate the effectiveness of the interventions that we're going to talk about implementing. The rationale for this project is basically that we want to show improved patient outcomes can result from reduced hospital readmission. We show that patients experience longer life and improved quality of life with reduced readmission rates. Patients will improve increased self-efficacy with improved self-management of symptoms. Self-efficacy is a psychological benefit that shows that a patient has a little bit more a sense of purpose and a sense of self-worth when they're able to care for their own self. And in addition, financial repercussions for hospitals and healthcare facilities will be reduced if hospital readmissions are reduced overall. In a root cause analysis, there were several reasons identified for possibilities as why patients are so frequently readmitted. Many of these patients suffer from multiple comorbidities, including other types of cardiac disease, diabetes, high cholesterol, having had strokes, or other diseases that decrease their self-care ability and their sort of physical reserve to deal with the symptoms of heart failure. Failure to adequately identify readmission risk upon the initial assessment. So we have a patient come into the hospital and we don't identify that they're going to be a readmission risk, fail to allow them access to all the resources that they could have, and then they end up back in the hospital very soon. Fatigue and other disease-related symptoms of heart failure lead to a decreased self-care ability. So some of these patients are physically not capable of caring for their own selves. So like I said, this is patients that have the decreased physical ability to cope with the symptoms of heart failure. There may be a lack of education for the patient. They don't understand what's going on with their disease. There may be a lack of compliance. They understand what's going on with the disease and they just choose to ignore the instructions they're given. Or finally, there's some research that shows that an increased lifespan just overall for all patients and increased diagnostic capabilities and techniques. We have more patients that are living with the disease in a chronic nature and being able to live longer with the disease than in previous years. So the PICO question for this research project has two parts. In patients with chronic heart failure, how does improved outpatient management versus frequent readmission for the symptom management, how do those two compare with the readmission rates in 6 months? And the second part of the question, in patients with chronic heart failure, how does improved discharge education compared with no education prior to discharge affect readmission rates in 6 months? Some evidence that shows that supports the changes that we would like to implement shows that patients with increased access to educational opportunities had improved self-care and improved self-care scores. So these educational opportunities would include printed material, educational meetings, and home visits even after discharge. Telehealth programs may help reduce readmissions by providing monitoring and treating symptoms in the outpatient setting. And finally, community-based care management can reduce all-cause mortality in elderly patients with chronic disease. Patients with fewer hospitalizations will improve quality of life. Obviously, they're not spending all their time here with us in the hospital. Reduced readmission rates will lead to improved patient outcomes. Encouraging self-management of treatment and diet compliance will lead to this improved self-efficacy, which is that increased psychological benefit for the patient. And in addition, financial repercussions for the healthcare facilities will be lessened with the reduced readmission rates. So the first intervention we're going to talk about implementing, the first recommendation that we have would be to improve education for the patients while they're in the hospital, at the time of discharge, and ongoing education provided in the home and in the outpatient setting after discharge. Continued educational support after discharge could use in-home meetings or in-home education or support groups. This education will need to focus on compliance with diet, medication, and the importance of physician follow-up. And this education will need to start with an formalized education plan that is provided to the nurses at the bedside that are taking care of the patient in hospital, and then those nurses will be responsible for rolling out that education to their patients. Rodriguez-Gasquez tells us that patients who were provided additional educational resources showed improved self-care in heart failure patients. The second recommendation we're going to talk about, or the second intervention that we're going to talk about implementing, will be utilization of telehealth nursing. And telehealth nursing involves the use of technology in the home to allow patients to communicate with healthcare providers still while in their home. So these healthcare providers, and that may include a nurse practitioner, or other mid-level, or a physician, they're able to monitor the patient's symptoms. They may be able to monitor several things such as weight gain and loss, urine output, edema, vital signs, medication compliance, their dyspnea level, their fatigue, any number of symptoms that go along with heart failure. These care providers are able to monitor these symptoms and help manage and mitigate some of these symptoms while the patients are still in their own home. Patients may require assistance from the hospital prior to discharge, initiating these telehealth nursing programs and making sure that all the technology and all the things like that are set up in the home prior to their discharge from the hospital, so that those resources are available for them immediately upon arrival home. There's no lapse in the time of care for these patients where they're left kind of on their own and would be at risk for readmission. So Black et al. Tells us that patients in a telehealth nursing program may experience reduced readmission rates. The third recommendation that we're going to talk about, or the intervention we would like to implement, would be increased utilization of community resources. So these community resources can include outpatient physician offices. They may include other support groups, in-home dietitian, community pharmacy medication assistance that may be available, or sort of these nurse-led care coordination services that can be provided in the outpatient setting. So proper utilization of these types of community resources requires a very good working relationship between your inpatient and your outpatient physician. And these two groups need to have a positive relationship wherein they can ensure that the inpatient physicians are taking care of the patients, getting them stable for discharge, and the outpatient physicians are capable and willing to manage their symptoms, keep these patients from coming back into the hospital again. Patients, of course, must be compliant with their outpatient physician follow-up. It's a very important point of education for these heart failure patients. The Coburn et al. Tells us that community-based nurse-led care coordination programs reduce readmission rates and all-cause mortality in heart failure patients. The way that we're going to evaluate this project is going to be twofold. We're going to need to get, obviously, some information regarding the readmission rates themselves. It's going to be the number of patients that are coming back into the hospital and the duration of time between their discharge and their readmission back to the hospital. We need to get this information at a baseline. And then we're going to collect data at about 3 months and at about 6 months. And the reason for these time frames is that the Centers for Medicare and Medicaid Services, which are responsible for a large majority of the financial reimbursement that's provided to healthcare facilities in this country, they penalize healthcare facilities for patients with heart failure who are readmitted to the hospital within 90 days. So that's about a 3-month time. So if patients are readmitted for any reason within 90 days, it doesn't have to be heart failure related, then the hospital is going to suffer financial repercussions for the care of that patient upon their readmission. So what we want to do is kind of work within that 90-day cycle and base our evaluations around us 3-month sort of periods. So in addition to tracking the readmission rates, of course, we also want to maybe try and track the financial penalties or the actual dollar amount that's being spent on these patients when they're coming back into the hospital. How much money is it costing the healthcare facility for these readmissions to take care of? And finally, the last thing we want to track would be the morbidity and mortality of heart failure related deaths over about the course of a year. Expected outcomes, of course, we want to see reduced readmission rates. We want to see improved patient outcomes. So for this, in the context of this project, we want to see increased self-efficacy of the patient, decreased morbidity and mortality, and reduced readmissions for diseases other than heart failure. And then finally, we want to see decreased financial penalties, which indicate to us there's an increased availability of resources for the care of other patients in the hospital. So as a nurse in a critical care unit who frequently cares for patients in an acute exacerbation of their chronic heart failure disease, I do have some personal obligations for the care of these patients. Number one, I'm responsible for providing the education that we've outlined to these patients while they're here in the hospital under my care. I want to make sure that they have a very full understanding of the importance of complying with their treatment regimen, with and understanding of importance of compliance with their diet, their medication, their outpatient physician follow-up, and just make sure they understand overall the progression, the prognosis of their disease process, and where they are in that continuum. I want to support patients when there comes time for discharge planning, ensure that they have all their needed supplies for self-management, such as a scale, access to transportation to the pharmacy and to physician offices, and access to their medications. I want to assist with discharge coordination with outpatient physician follow-up, make sure these appointments are already made when the patients are discharged from the hospital, so they have very little reason not to make it to those appointments within 1 to 2 weeks after discharge. And I want to encourage and support patients with frequent readmissions to become more active participants in their own health care and to hopefully prevent other readmissions in the future. Finally, in conclusion, heart failure readmissions are a significant problem for healthcare. The recommended interventions that we've discussed in this project will reduce readmission rates. Though all the positive results of the proposed changes will benefit patients, the main outcome that we're focused on is the improved patient outcome that we discussed in the previous slide. These outcomes, again, include improved quality of life and increased self-efficacy, and then, of course, decreased morbidity and mortality for heart failure as well. Finally, the ultimate goal is for patients to feel confident with the resources at their disposal so that they may become capable agents of their own health care. We have a reference. Any questions?